Hi, and welcome to What is This Shift? I'm your host, Elle. I'm an LPN. And today's episode is going to be on what the hell is an LPN anyway? Because I think that there is an actual deficit of knowledge when it comes to what an LPN is versus an RN versus a CNA. And while I can expect that from the general public, I'm very sometimes dismayed at the lack of knowledge within our own healthcare family, our own healthcare little community, our little niche of jobs in society, our vocation, our profession, whether they consider us professionals or not. Y'all don't know what LPNs are. Now, this episode is not going to focus on the relationship that we have with each other. That's coming up in the future. This is just to strictly be factual. You know, these first couple of podcasts are going to be more the drier sort of educational type stuff. It's not going to be the anecdotal, subjective opinion stuff that's going to fire people up. So stay tuned, though. That is coming. And speaking on that, I do want to say that anything that I'm saying here, strictly my opinion, maybe a couple million other more people, but strictly my opinion, and does not reflect my past, present, or future employers. That being said, I'm still rocking a COVID after long COVID. I had COVID a little bit over 8 weeks ago, but I do have a history of asthma and mild COPD, and so when it hits hard. So I finished a course of prednisone. Now I'm doing the steroid inhalers, the duo nebs, and it's allergy season. The trees are starting to pollinate, so I'm miserable, y'all, and I hope that it's not too irritating to listen to me right now, because my voice is definitely kind of out of sorts. But that being said, thank you for tuning in. You would think that episode 2 would segue, because the first one talked about the birth of nursing homes, right? So you would think that episode 2, a good segue would be, let's talk about the different branches of long-term care. For example, you see, there's a hospital, but within that hospital, there's the different units and departments, right? So it's the same with long-term care. Where are people working in long-term care? What do they do? And I do want to get into that. That'll probably be episode 3. But I want to talk about the most important part of long-term care, which is the clinical staff. Now, this is not to say that the other staff, the ancillary staff, is not as important. Activities, dietary, social workers, PT, of course, you're all vital to the community that we serve. Absolutely. But when it comes to a matter between, life and death, typically it's the clinical staff. Although there are housekeepers I know that have walked into a room and been like, yeah, no, this is not okay. But what I'm trying to say is that it's the clinical staff who has the ultimate moral and legal responsibility to look after these patients. But they're not called patients in long-term care. They're called residents. And the reason for that is pretty simple. They live there. This is their home. So when you rent an apartment building, you're referred to as a resident of that apartment building by, the company that owns the building. So it's the same thing. If you live there, you're a resident. If you're just staying there temporarily, like you're on the rehab hallway, you're typically a patient. But I may sometimes use the terms interchangeably, because if you're an LPN that goes to home health, then they're back to being patients. So that's why I may use the term but basically the people we're taking care of, okay? That's who I'm talking about. The staff who's primarily responsible for taking care of these people. It's a trifecta in long-term care. Your RN, your registered nurse, your LPN, your licensed practical nurse, and your CNA, your certified nurse assistant. Now, if you're in the state of Texas or California, you're not an LPN, you're an LV as in Victor N. The V stands for vocational. Why? I don't know, because California and Texas are always on their own thing. They're two diabolically kind of opposing states, politically, but they're each kind of their own country, right? So I don't know. They just do things differently out there. But in vocation, I guess the word has an implication. It's more like a technical training, like the blue collar of nursing, right? Whereas practical, I don't know. It's like we're doing the practical stuff of nursing. Not practically a nurse, like I've heard some fools say. But that's the only difference. It's only 2 states. Now, CNA is Certified Nursing Assistant. If you go to the state of Ohio, you are a STNA, which is a state-trained nursing assistant. Some states just call you an NA. You're a nursing assistant. And then in Michigan, if you are working in acute care or the ER, you're a CNA, a Certified Emergency Room or Emergency Nursing Assistant. So you may see different acronyms depending on the state that somebody's coming from, and then you'll see people arguing on the internet because it's the internet. But yes, there's different initials for different stuff. Like CNAs in a hospital are usually known as PCTs, Patient Care Technicians. If they are in a nursing home, if they're in like an assisted living or a memory care where it's not required to be a certified nursing assistant, they would probably just be an NA, or they'd be known as a caregiver. And we'll get into the assisted living stuff because that's a different entity from nursing homes. But it is part of the long-term care arena that I'll be talking about in the next episode. So for now, a licensed practical nurse is a nurse that was created in the 1930s and 40s. So we're going to strap in again, go in the Wayback Machine. Prior to the 30s and 40s, most people were getting taken care of at home. I'm sure you've watched Little House on the Prairie and you saw the doctor went to them. That did not change throughout the year. Like, doctors made house calls. So most people stayed at home when they were ill or they had stuff going on with them. And the hospitals were seen as a last resort, especially because they were still kind of like poorhouses in a sense, right? And then, the Great Depression hit. Hospitals were being overwhelmed, mostly because now they were starting to be treated more like medical centers. As sanitation had improved, they were getting some trained staff in there. And so people were starting to utilize hospitals more and more. But because of the Great Depression too, there was a nursing shortage. And I feel like there's been a nursing shortage since Florence Nightingale was born, but different reasons. Okay, so the reasons back then, about 100 years ago now, which is phenomenal to think about now, that really modern nursing and modern hospitalization is only about 100 years old, a little less than 100 years old. Prior to that, it was still kind of sketchy to be in a hospital, but more and more people were starting to trust the process and starting to go. And nurses became nurses, RNs, through the hospitals. They were hospital-based diploma programs, typically about 2 years of straight working in the hospital. It was like clinicals for 2 years long. But it was not very structured. It was not, well-regulated. Different hospitals had different things going on. So the training mainly focused on hands-on work. So these students were working real hard and they weren't really getting paid. The hospitals were completely exploiting them and taking advantage of them, using them as cheap nurses, cheap labor. And nursing back then was not like, it wasn't a career that many people wanted to get into. First of all, women, okay? Because let's keep it real. Women became teachers or nurses if they were even deemed able to work outside the home, because really women weren't working outside the home. And so if they did, it had to be in these roles that the patriarchy didn't want. Nobody wanted to take care of kids. Like, none of the patriarchy, they felt like that was a woman's job. And they didn't want to take care of anybody, like women being the nurturers and being the caregivers, the caretakers of the world. It's like, yeah, you can be teachers and you can be nurses, or you can be a secretary. pretty much period. Okay. Those were the main traditional professions that women worked in outside of the home. But it wasn't a very attractive like thing because it was very physically demanding, as it still is. The hours sucked, right? They're working 12 plus hours on a regular routine basis, as we are now. The pay was crap. Excuse me. Some may argue it still is, given what we do. And it was very strict, but especially strict on women. And I mean, you know, you can kind of understand it goes back to what I was just talking about, the patriarchy. So it wasn't something that people really wanted to get into. So now there was this shortage, and this was problematic during the Depression, but then World War II entered the room. And that's, as they say, when shit got real. Because now RNs were joining the military. So they weren't even around anymore. And the hospitals were becoming more and more crowded. And this led to, what are we going to do? We got nobody to take care of these people. So the hospitals were like, look, we have to do something. We have to find a way to staff this place. So let's create a nursing position that doesn't take 2 or more years for training. And let's get these people trained ASAP and on the floor and doing the things. Like, forget all the other stuff that might take them away from patient care. We're just going to focus on the patient care. So the hospitals, you know, incepted this. Educational training programs adopted, a core way to, train the LPNs. So now, instead of taking 2 years, it might take a year. And then the states got involved and started to legitimize the position by licensing it. So now we had these licensed practical nurses who were basically never meant to replace RNs, but to supplement them, more or less, and to do the nitty-gritty day-to-day tasks. You know, RNs were trained to assess and to make clinical decisions and do all those types of things, care planning, although wasn't care plans as we know it today. But they needed somebody to do all the other stuff. And when I say other stuff, I mean the stuff that like the volunteers were doing. Because prior to all of this, prior to the 1960s, CNAs did not exist. What they had were volunteers, and they had candy stripers. Because the uniforms that the volunteers wore were just that, like white dresses with a red stripe going down. They looked like little candy canes. So they were called candy stripers, and they were doing untrained, mind you, like taking care of these people. So they needed consistency, though, because while it's wonderful and it's great that people would come in and volunteer their time, it wasn't consistent and people didn't last long. So they needed something that had structure, that had legitimacy in terms of like, hey, these people have been trained properly. They know what they're doing and where they're going to get paid, because that's how you retain people, is that you create it as a job. So that's how CNAs came into being. But that wasn't until the 1960s, right? Okay, so long story short, LPNs were created because there was a huge need and a huge gap at the time in terms of patient care. And so they needed somebody to come on the job that could do the basic tasks day to day and do the implementation of whatever the care planning was. Hence, LPNs were born. Now, in modern times, our role has evolved, but there's still a lot of confusion in terms of what the different roles do. Now, I'm trying to simplify a very complicated thing. All right. So forgive me if I seem a little flustered with it, because I'm trying to condense it and simplify it and sort of dumb it down for people and not also bore everybody to death. But like RNs went from hospital-based diploma programs to going to college. Okay, whether that was community college, going to a private nursing school, or to a university, nurses now were getting collegiate educations, meaning it became a degreed program. So for the least amount of education, that would be, excuse me, an RN with a associate degree, an ADN, and that's typically your community college nurse. Then the LPN only has the nursing core classes. The RN and the LPN take the same nursing courses, right? We learn pharmacology. We learn peds. We learn OBGYN. So we all go over the same different, body areas. We do cardiac. We do the kidney. We learn it all the same. However, the RN programs do go a little deeper into the pathophysiology. They go deeper into pharmacology. They go deeper into clinical reasoning. Because, basically LPNs, it's all about implementing. And the RNs is doing the assessment and the planning and the decision making. So RNs basically learn, why is this happening and what should we do about it? And then the LPNs are, okay, we're going to implement the treatments, the medications, but how do we do this safely and properly? So, but we learn the same stuff. Like, I'm learning about the kidneys the same way an RN is learning about the kidneys. The difference between the LPN and the RN 2-year is that LPNs don't have to do all that other gen ed stuff. We don't have to take algebra. We don't have to do world history. We don't have to take, a humanities class. We don't have to take sociology or psychology. Both have to take anatomy and physiology. I mean, because that helps in nursing. And then the LPNs typically learn nursing math, right? So they don't have to take like a math course behind it. Now, I personally have basically an associate's degree. I think I'm one class, a couple credits behind. Like I'm three credits away from an associate degree. So I've taken those gen ed requirements, but my knowledge of world history ain't going to help me assess whether Aunt B's having a stroke or not. You know what I'm saying? So there's a lot of importance that people have placed on education to basically say that an educated nurse is a better nurse. And that's not true. Okay. Is it the same curriculum though? No, it is not. The RN definitely goes more in depth with the nursing theory, which doesn't really, at the end of the day, yes, critical thinking, although critical thinking to me is not something that can be taught. I think it's an inherent skill. You either have the abilities to do it or not. They do have classes on it. I took a critical thinking class and I actually got an A, but I've met plenty of nurses that seem to be lacking this vital skill, which basically separates a great nurse from a terrible nurse, in my opinion. But the ADN curriculum is broader and deeper on like complex conditions, leadership and delegation, because, the leadership roles, the management roles, the director of nursing roles are RNs. So, of course, they're going to focus more on that, whereas LPNs are not. LPNs are utilized in the hospitals, not like they used to be. They're usually utilized now more like techs. But most of the LPN jobs have been handed over to long-term care. For a long time, there was a rumor that, LPNs are being phased out. No, they were being phased out of the hospitals, but they weren't going to phase them out, period. And so a lot of people are like, don't even become an LPN, just go straight to RN, which isn't bad advice. I, like many a nurse, said, I'm going to go get my LPN first, make some money, and then I'll go back and get my RN. And I'll take the bridge program, the LPN to RN bridge program. Excuse me again. That seems to be the wiser way to do it, but it's not, because trust me, once you're out of school, nursing school is brutal. I don't care whether it's LPN or RN. And once you get out of it, it's very difficult to want to go back to that. It's just better to get it all out of the way. Just go get your RN. Seriously. I wish I had done that, but that's okay. And that's why many LPNs do go back to get their RN. And you'll see that there's actually a lot of people who go up the ladder, right? They kind of go up the nursing food chain. They start at the CNA, become LPN, go RN, BSN, NP. So, and that's the whole thing. Is that just because somebody's an LPN doesn't mean that they don't have the ability to be an amazing RN or an amazing NP. And just because somebody did do all that education doesn't mean that they're good at their job. But perception is reality, and people perceive more education or a higher level of this healthcare caste system of being more qualified, more knowledgeable, and better at what they do. When we all know LPNs that can run circles around an RN, and we all know CNAs that know more than an LPN on the job. So it's a generalization, and it's not a fair one. But also because most of the general public only sees RNs, because most of the general public is only familiar with hospitals, the perception is that a nurse is an RN. And that's on every TV show, every movie. I mean, nobody ever talks about LPNs. Like, that's what I mean. Most people don't even know what we are. So it's kind of a sad reality that these positions were all created. I mean, the RN was there to help the physician, right? The LPN was created to help the RN, and then the CNA was there to help the LPN or the RN, which all of us end up helping the MD take care of these people, matter of life and death, and everybody's just as vital. I mean, to me, a CNA is my eyes and ears because I don't have the time or the ability to get to know everybody. I don't see them naked every day. I don't feed them. I don't, toilet them. So I can't tell if there's a change in their condition on that level. I have to go by the objective things like they have a fever or their blood pressure is higher. But the CNA can tell me about subtle things, or they're the first ones to notice a bruise. They're the first one to notice a cut. A great CNA will save not only a life, but my ass, right? A terrible one is a liability for everybody. But the bottom line is that, even though the perception is that, CNA is the low person on the totem pole, I think they're actually the most important person in the room because they are the ones that interact with these people on such a regular basis that if they don't report even a subtle change, that could definitely matter in the long run. And then the nurse takes that information, the LPN, they do their own assessment because we can do ongoing assessments. We just can't do initial. I'm going to interrupt myself for a little bit to tell you how important this actually is. I worked second shift in a nursing home on a hallway. It was my regular hallway, and I always followed the same day nurse who was an RN on that same hallway. Now, she had been a nurse since Jesus, okay? I think she was actually the nurse at the Last Supper. I mean, she's still wearing white, right? But she had checked out a long time ago, like she retired in her own mind. I think she was just there in body. She didn't, I don't want to say she didn't seem to care. Maybe she never did. I don't know. Every single day, my report from her was everybody's fine. Everybody's good. I mean, maybe she had to change a Foley or maybe somebody had an eye doctor appointment, but basically everybody's all good. In my first month of working there, I had to send 4 people out. And my charge nurse came to me one day. She's like, God, you know what, Elle? Every time you send somebody out, like they stay out. Like they're out for 2 weeks, not 2 hours. Because 99% of the time you send somebody out, they're back within a couple hours. So she's like, what the hell? I'm like, I don't know. I'm just assessing. And these are my findings. Granted, there are some things like viral illnesses tend to get worse at night, as the sun goes down, kind of like sundowning. Cortisol levels rise, and that tends to make people feel a little sicker. But yeah, I don't know what was going on there, but you could argue that my LPN skills were way more on point than her RN skills, because I'm sending people out that were critically ill that she wasn't, that she was saying were fine. So, I'm just saying, we all know inside these four walls that these acronyms don't matter, right? But what I'm trying to say is that they absolutely do. So the CNA reports a finding. The LPN has to act on that. They go and they do the assessment. If they blow it off and the buck stops there, that's it. That patient is in trouble. So it takes a good LPN to then take, the CNA seriously, go assess, go look for themselves, and then report it to the RN and to the physician, who then do their thing and ultimately help this person. That is how it's supposed to go, right? And that's typically how it does. I would say, to be fair, that's mostly how it goes. But there are glitches in every system. But that's why everybody's vitally important, because everybody can make or break the other person. And I'm going to get into the relationships that we have with one another in a different episode. But for now, I just want to outline and illustrate what it is that we do. Hospitals don't utilize LPNs anymore because they are limited in what they do. So when they do utilize them, it's as technicians. This is frustrating to some RNs, because the RNs are like, well, how are you really here helping me? You're just kind of in my way if you can't go start this IV line, or you can't go hang this bag of blood. Other than that, though, there's very few things that the LPN can't do, clinically speaking. So there really shouldn't be too many tasks that fall on the RN that make it an impediment to an LPN being around. But I have seen that argument online. But, all I'm saying is that I'm going to be discussing the relationships later. For now, just understand that these are the roles. And because I'm talking in terms of long-term care, I'm not talking about hospital nursing. I can tell you that the LPNs and the RNs, for the most part, do the same things on the job. The only time I need an RN to do something for me on the floor is if it involves TPN or maybe a PICC line, flushing a central line. I'm not allowed to do that. I can do a HEP block, like I can do a midline. I can hang a bag of antibiotics. I can't start the IV. Now, as an ER tech, I learned how to, and I'm a certified phlebotomist, so I would know how to do it. But legally, it's not within the scope of my practice, so I don't do it. And that's the other thing, too. Just because people can do stuff, they're just not supposed to. Does it always work that way? You know what? I don't know. I'm going to keep my mouth shut on that one right now. But for now, just understand that everybody has a legal scope of what they're allowed to do and not do. So that's why it's really important to know what that is. Because if somebody's trying to delegate something to you, like if the LPN's trying to tell the CNA to do something that's without their scope, and the RN's trying to tell the LPN, you need to know your lane and when it's not okay to cross it, right? Yeah, that's definitely something coming up in a future episode. But anyway, thank you for listening. I hope you got something out of this. I hope you understand a little bit more. And of course, as I go on with further episodes, it'll become more and more clear what we actually do and how important and vital we are to the healthcare system as a whole, not just in the long-term care community. But again, thank you for tuning in. Please like and share, pass it along. And if you have any ideas for podcasts that you would like to have discussed, or if you would like to be a guest interviewed by me, or you have commentary, please, by all means, reach out to me and we'll make it happen. Thanks again for tuning in. Have a blessed day.